Welcome back. This is a new series. We are starting with the operative findings in various clinical cases, and in this section, we'll briefly describe the important findings in the history and examination part, and we'll go through the possible findings that we may see during operative procedure. Just to give you an idea how the words usually we are going through the theory part or in the cognitive domain, how these words are important for a clinician and what are the findings that we usually get in these type of cases. So this is the first case I'm starting with, and later on at regular interval we'll go through the various clinical cases along with their findings, just for the purpose of learning. Okay, so I'm starting with this first case, and a patient, 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 a patient in 30s presenting with off and on abdominal distension for the last 2 years with few episodes of features and clinical presentation suggestive of subacute intestinal obstruction, SAIO. And those episodes, they were relieved on conservative management most of the time. Now at this time, there is history suggestive of loss of appetite and there is significant loss of weight in the last 6 months in this patient. There is also presence of family history and the family history was positive for pulmonary cox or pulmonary tuberculosis 3 years back. So we planned this patient for diagnostic laparoscopy, suspecting abdominal cox after relevant blood and imaging study. This abdominal tuberculosis is one of the indication nowadays for doing a diagnostic laparoscopy, and it is very useful in this scenario. Let's see what are the intra-abdominal findings of abdominal tuberculosis. We took the peritoneal biopsy from multiple sites, and that was confirming the diagnosis of abdominal tuberculosis. Few of the findings are very important, like omental cake appearance, presence of ascites, presence of tubercles, whole of the peritoneum is affected, the hyperemic bowel, almost whole of the abdominal cavity, including the solid visceral organs. The lesions were present in this patient. So let's see what happens in the operative part. This is one of the video I have not presented to YouTube. This is in private mode and I'm taking the help of the same video in order to place it in front of you. This is the heading is abdominal tuberculosis diagnostic laparoscopy. Now here you can see this is the intraperitoneal view of first port through the umbilicus, the umbilical region, the infraumbilical crease, the telescopic port was placed in this patient, and these whitish spots, if you can see here, these are tubercles. So let's start with the video. Now here you can see the imaging of the intraperitoneal part. All these things, these are tubercles affecting the inside of anterior abdominal wall. Now here you can see this is liver, right? This is right lobe of liver. This is the perihepatic fibrosis, the perihepatitis, the adhesions. Again, the multiple small nodules, whitish patches. These are, if you can see this white, the larger one, these are tubercles, the colonies of the Mycobacterium tuberculosis. The liver is very much adhered in this area. This below the zophisternum area. This is gallbladder, if you can see, and this is a mesogallbladder, again started with various tubercles. And usually what we do in diagnostic laparoscopy, the surgeon, I'm just using a 30-degree laparoscope, 10 mm in my right hand, and in my left hand I am using a single working instrument, like you can see here. Here you can see the prominent blood vessels, the omentum. This is classical example of the omental cake appearance, and here you can see the presence of ascites. Here you can see the 5 mm port. Through the 5 mm port I am just demonstrating you. This is ascites, and in this video I have already sucked out around 800 ml of ascitic fluid beforehand, and still the ascitic fluid is present here. And this is what I was talking about, the appearance of omentum just like a cake, also known as omental cake, like this. These are the classical finding in any case of abdominal tuberculosis. And another important finding is that the cecum is usually not present in the right iliac fossa region. It is usually pulled up, and sometimes the cecum may be present in right lumbar or even in subhepatic area. So this is the video demonstrating the various findings in the patient of abdominal tuberculosis. So that is all. The take-home message is that we must not afraid to go for a diagnostic laparoscopy in patients of intestinal obstruction, and especially if we are suspecting the abdominal cox. With the help of after doing this diagnostic lab, the advantage is we can always take the biopsy. The biopsy part I'll again post another video, the same continuation of this patient as a part of it. So till then, take care, stay safe. Bye bye.